This 3D rendering illustrates bile flowing from the liver into the gallbladder. In healthy adults, this pear-shaped reservoir holds 25 to 30 milliliters of fluid. The gallbladder mucosa concentrates this fluid by 5 to 10 times, actively absorbing water, sodium chloride, and bicarbonate through its membrane. For safe surgery, we map boundaries. Calott's triangle comprises the cystic duct, common hepatic duct, and cystic artery. Modern practice expands this into the hepatocystic triangle, setting the liver surface as the top boundary. It contains the cystic artery and lymph node of Lund. Surgeons rely on a primary external anchor point on the undersurface of the right liver lobe, Rouvier's sulcus, which marks the right posterior sectoral pedicle. This maps the R4U line, connecting the roof of Rouvier's sulcus across segment 4 to the umbilical fissure. The green shading indicates the safe surgical zone. Dissection must remain ventral to this line to avoid the red danger zone housing the common bile duct. Even with precise mapping, anatomical variations pose severe risks. A tortuous right hepatic artery, known as a Moynihan's hump, can loop dangerously close to the gallbladder neck, creating high risk for vascular injury. Another trap is an anomalous low insertion of the cystic duct. Instead of joining the supraduodenal segment, the duct joins the biliary tree far below, sometimes reaching the retropancreatic space. Safe biliary surgery relies on strict adherence to these spatial landmarks. Visual assumptions in the porta hepatis lead directly to iatrogenic damage. This simulation shows the genesis of cholesterol stones. When bile becomes supersaturated with cholesterol, the lipids precipitate, allowing cholesterol crystals to nucleate and aggregate. This crystallization is mechanically accelerated by impaired gallbladder motility. When the reservoir fails to empty completely, the resulting fluid stasis provides the environment for stone growth. Pigment stones follow two separate pathological pathways. Black pigment stones consist of calcium bilirubinate, associated with chronic hemolytic disorders or hepatic cirrhosis. Brown pigment stones form due to localized biliary environments. They are the result of bile stasis, combined with bacterial infections, foreign bodies, or parasites. Recognizing a stone's composition identifies the specific systemic or functional failure occurring in the patient, whether it be hemolysis or bacterial stasis. When a patient presents with biliary colic or right upper quadrant pain, ultrasonography is the first-line diagnostic tool. It is rapid, non-invasive, and highly sensitive for stones. To confirm acute calculus cholecystitis, the ultrasound must demonstrate specific markers: a gallbladder wall thickened beyond 3 millimeters, the presence of pericholecystic fluid, and a sonographic Murphy sign. This split-screen graphic demonstrates why CT scans are unsuitable for screening uncomplicated gallstones. While the ultrasound clearly detects the calculus, the CT scan misses the same stone, illustrating a failure rate of approximately 25%. Computed tomography is instead reserved for staging hepatobiliary malignancies or evaluating severe complications, such as perforations, emphysematous changes, or abscesses. For detailed ductal anatomy, MRCP is the non-invasive gold standard. In contrast, this radiograph shows an ERCP. Notice the endoscopic scope actively retrieving stones. ERCP is a therapeutic intervention, not a primary diagnostic tool. When initial ultrasound results are inconclusive, clinicians trigger a HIDA scan. In this sequential series, the radiotracer fills the liver and extrahepatic ducts, but the gallbladder remains invisible, confirming a cystic duct obstruction. Imaging modalities must be sequenced purposefully to secure accurate diagnoses while protecting the patient from unnecessary invasive risks. The Tokyo guidelines require local inflammation, systemic signs, and positive imaging. Grades dictate intervention. Grade 1 allows early cholecystectomy. Grade 2 involves prolonged symptoms or severe local inflammation. Grade 3 presents major organ dysfunction, demanding critical supportive care and urgent drainage. By linking objective patient data to a rigid severity grading, the Tokyo guidelines remove guesswork from ward management and dictate a precise operative timeline. Before initiating a cholecystectomy, the preoperative baseline must be secured. This includes a liver function assessment, a coagulation screen, and administering a second-generation cephalosporin at the time of anesthesia induction. Deep vein thrombosis prophylaxis is also mandatory. Standard protocol requires both subcutaneous heparin and anti-embolic stockings before the patient is positioned. Intraoperatively, preventing bile duct damage relies on achieving the critical view of safety. This wireframe illustrates the Strasberg classification of bile duct injuries, ranging from E1 to E6. These complications result from anatomical misidentification. To achieve the critical view, 3 steps are non-negotiable. First, as shown in this diagram, the surgeon must thoroughly clear the hepatocystic triangle of all fibrofatty and soft areolar tissue. Second, the gallbladder must be separated from the liver bed. The dissection must expose at least the medial third of the cystic plate, leaving it attached to the liver. Finally, the surgeon must visually confirm that exactly 2 structures enter the gallbladder, the cystic duct and the cystic artery. If this view cannot be achieved, the team must employ a timeout. Surgeons are required to pause and reevaluate if they encounter red flags, like severe adhesions, gangrenous inflammation, or Maritzi syndrome. When the critical view is impossible, proactive bailout strategies are initiated. These include performing a subtotal cholecystectomy or placing a Foley catheter for tube cholecystostomy. The final bailout is converting the procedure to an open subcostal Kocher incision. This restores tactile feedback and allows for safer exposure of the porta hepatis. A bailout maneuver is a demonstration of surgical maturity. Shifting protocols prevents irreversible biliary injuries. When a patient presents with jaundice or severe abdominal pain in the postoperative period, the protocol requires urgent ultrasound investigation to rule out ductal damage. The most common anatomical failures are bile leaks originating from the cystic duct stump or post-cholecystectomy syndrome, caused by stones retained in the common bile duct. Beyond routine adult pathology, pediatric biliary conditions operate on aggressive timelines. Infants diagnosed with biliary atresia require a Kasai portoenterostomy before they reach 8 weeks of age to establish viable bile flow. Coloductal cysts present a very different challenge. Because these congenital dilatations carry a high risk for malignant transformation over time, they require radical excision with a Roux-en-Y reconstruction. When malignancy does arise in the ductal system, it is highly invasive. Cholangiocarcinoma is linked to primary sclerosing cholangitis and parasitic infections. A surgical resection achieving negative margins is the only curative option. Gallbladder cancer is equally insidious. Its presentation mimics benign gallstone disease, leading to late discovery, frequently as an incidental finding after a routine cholecystectomy. If transmural disease is identified, a subsequent radical en-bloc resection is mandatory. Routine cholelithiasis and aggressive cholangiocarcinoma both demand the same adherence to spatial landmarks and clinical algorithms. In the biliary tract, these protocols are the protection against iatrogenic injury.